Hello everyone, welcome back to my channel. So in the previous lecture we have studied about the peptic ulcer disease, presentation, causes. Now we are going to continue our topic, that is complication, management, treatment and the complications of surgery. Now we will talk about the complications. First is bleeding. If it is gastric ulcer, it will bleed of gastric artery, and if it is duodenal ulcer, then gastroduodenal artery will bleed, profusely bleed. Second is perforation. If it is anterior, it will relate to arteries, and if it is posterior, so it will go to the peritoneum, causing peritonitis. Itis, peritoneum inflammation. Third is gastric outlet obstruction. Fourth is pancreatitis. Fifth is malignant potential, means a gastric ulcer will have malignancy risk of 1 to 4%, and the biopsy is must. Now we are going to study about the management. Investigation of choice is endoscopy plus biopsy for the gastric ulcer. And the screening test for H. pylori is serology. It is cheap, and if it is negative, and it can be positive. If positive, it can be active infection and the chronic infection. And it has main drawback, like it can't identify a person is infection is acute or chronic. We have non-invasive tests like C13 urea blood test and fecal antigen test. The main advantage is it will detect the active infection, like person is suffering from infection or not. But they both are expensive, and fecal antigen test is inappropriate for the patient. Now we are going to study about the invasive test. We have studied the investigation of choice is endoscopy plus biopsy, and it is the most accurate test. We can do rapid urease test, but it has less sensitivity. And we can do microbial culture, which is a gold standard, but its sensitivity is less and the response is late. So what is the treatment of this patient with the peptic ulcer disease? If the patient has H. pylori positive, we will do eradication therapy because it is suffering from some bacterial infection. And if it is negative, we will simply give some drugs like PPIs. And if a person is taking NSAIDs, we will tell the patient to discontinue these drugs, and we will do some lifestyle modification, like if a person is smoking, we will tell the patient to stop the smoking. And if the person is taking alcohol, a person should stop taking the alcohol. And in some cases, these are refractory cases, and we will do surgery. In the H. pylori positive cases, we will do triple therapy and quadruple therapy. Like in the triple therapy, we have CAP, clarithromycin, amoxicillin, and PPIs. We will give 500 mg of drug of clarithromycin, 1 gram of amoxicillin, and 20 mg of PPIs like omeprazole. And we will continue these drugs for 10 to 14 days. If a person is resistant to the amoxicillin, so we will replace amoxicillin with the metronidazole, like clarithromycin, metronidazole, and PPIs. And if the triple therapy fails, we will give quadruple therapy. PPIs are constant, always constant, like omeprazole. Second is tetracycline, metronidazole, and fourth is bismuth. We can do urease breath test for the check of eradication, like H. pylori is eradicated or still present in a patient. We have studied in the refractory cases, we will do surgery. So in what cases we will do surgery? In emergency cases and elective cases. In emergency cases, like ulcer is perforated and hemorrhagic. In elective cases like complications starts coming, increasing, or recurrent ulcers are taking place. We will do partial gastrectomy like Billroth 1 and Billroth 2. In Billroth 1 case, we have stomach and we have duodenum. So we will resect that part of stomach in which the ulcer is present, and we will attach this leftover part to the duodenum. So it is gastroduodectomy. In Billroth 2, we will attach the gastric to the duodenum. So it is gastrojejunostomy. So what are the complications of these surgery? We have attached the gastric from the duodenum part. So some reflux will take place, which is known as bile reflux gastritis. Second is recurrent ulceration, and we will have also dumping syndrome. It can be early or it can be late. Like we have joined these gastric from the duodenum. So a person is taking food and it will rapidly absorb from the stomach, and it will collect here, which acts as an osmotic agent and starts collecting fluid here. So fluid loss will take place through diarrhea and will cause hypotension and tachycardia in the patient. And if it is late, person is taking food, it has absorbed from the stomach, but it goes to the duodenum, it is rapidly absorbing, like carbohydrates is attracting insulin for the absorption. So it will cause reflux hypoglycemia. Dumping syndrome is important, but we will discuss in more detail in the other module. So these are the complications like bile reflux gastritis, recurrent ulceration, and dumping syndrome can be early or can be late. We have studied about the surgery, we have studied about the therapies and complications, presentation, causes which was H. pylori and that. So this is the peptic ulcer disease. Thank you.